to mute your microphones throughout the presentations. And if you have questions, we'll moderate them through the chat function, and we'll get to them after both speakers have completed their presentations. So the subject, the two presentations we have today dovetail very nicely between palliative medicine and psycho-oncology. We have two super speakers in Dr. Fahmi Ismail and Dr. Aoife Lowney, and they'll be presenting on no doubt the early intervention, integrated care, and biopsychosocial focus that both psycho-oncology and palliative medicine share from the very beginnings of these specialties. So without further ado, I'm going to introduce Dr. Fahmi Ismail, our first presenter. Dr. Ismail is a consultant psychiatrist here at Cork University Hospital, specialising in the delivery of psycho-oncology care to adult patients with cancer. Fahmi has received his degree in medicine from University College Cork in 2009, and is one of our own, having completed his training in psychiatry in Munster and in Ireland, completing training with the College of Psychiatrists in 2018. Dr. Fahmi has wide interests, including psycho-oncology, liaison psychiatry, and research interests in mental health comorbidities in cancer, including steroid-induced mental disorders, and also has an interest in digital transformation in healthcare. After that introduction, Fahmi, I'll hand it over to you now at this point, and we look forward to hearing your presentation, The Impact of Psychological Distress Among Cancer Patients.
Great. Thanks, Prof. Cassidy. So I just share the screen there. Okay, so can everyone see the screen there? That's okay. Yeah. So so I'll probably zip through my presentation today. So the topic that was given to me is quite a large topic. So I do try to focus some of aspects of the impact of psychological distress among cancer patients. So so just a quick disclosure. So I'll start off with the definition of distress. So the National Comprehensive Cancer Network has used or coined the term distress to encompass the unpleasant experience or one experience as they go through cancer journey. This can include physical symptoms, psychological, and also spiritual and psychosocial. So the definition of distress by NCCN, it is unpleasant experience. It can be psychological, can be in behavioral, emotional, social, spiritual, or physical nature that interfere with one's ability to cope with the cancer, its symptoms, and also treatment. So it can encompass numerous, I suppose, attributions. So patient can say they're sad, or they worry, not able to sleep, a lot of pain, not able to adjust. So a lot of terms are used to describe what distress means. And obviously distress is a continuum. It can be mild to severe, and it can change also over time. So why do the NCCN use the term distress? So why not anxiety? Why not depression? So the first reason is that to emphasize that the cancer-related suffering or distress are multifactorial beyond clinical disorder framework. For example, we're coming from psychiatry, we're so used to have this definition of depression, anxiety, what it means, the clusters of symptoms required to diagnose. But distress are a bigger spectrum of issues. So it can be due to biological cause such as pain. Someone in catabolic state can present it with suffering, social, financial problems, burden to family, issues around existential and spirituals, and also psychological disorders such as depression and anxiety disorder. There are perceptions of distress in cancer that can be a normal response. However, there's a clinically significant level of distress in a subset of patients that interfere with the ability to cope with the cancer journey. So when we talk about the term distress, another reason why NCCN used the term distress is also to somehow to destigmatize one accessing support around psychosocial care. There was a study that was done back in Australia in 2014. They looked at a cohort of patients who reported high level of distress. So we talk about distress thermometer. If you look on the image there, this is the NCCN's has a visual analog that used to self-report the level of distress between 0 to 10. So 4 to 5 usually considered a high enough distress, and they are also attributes or corresponds to some form of psychological comorbidities. So in this Australian studies, then they look at around 300 patients at the time, and they look at patients who scored 4 or more distress, so considered moderate to high distress. Out of 311 patients that they were asked, a majority of the patients, around 70% of patients, decline help. They don't want help, and some of the barrier of them to get help is because they feel that distress that they actually experience are not severe enough to require any help. So in a way that the term distress that are used are with the hope that it destigmatized that people are more likely to accept psychosocial care. So the NCCN introduced the distress thermometer and the problem checklist as a way of a screening tools that are used for clinicians to identify needs and also address them appropriately. So distress extends along continuum. It can be normal feelings such as sadness and fears, but it can also range into a severe clinical disorder such as depression, anxiety disorder, panic disorder. It can range from transient distress to clinical disorders. If you look at the image there, that's actually taken from the model of care from psycho-oncology. It was published in 2020 that shows the degree of distress and it ranged from transient distress to an organic state and psychological disorders. So how common are this prevalence of distress in cancer patients? So obviously distress, it's actually fairly universal in cancer populations. But if you look at clinically relevant or clinically significant distress, up to 50% of our patients reported significant level of distress. This is taken from a study that was done in Germany, looking at multi-center studies looking at over 3,000 patients, that 52% of patients reported distress levels of above 5 if you look back in the distress tools. A majority of them reported fatigue, sleep problems, and also sadness. And they're also strongly associated with presence of other problems. And then there's another aspect of how good does a cancer clinician, identify patients having distress. There's a study that was done again in Germany. So they're looking at over 2,000 patients that have presented with significant distress. So this distress thermometer score over 5. When you look at the physician trying to see the concordance, how close they are identifying the distress, only 1 in 10 actually a patient with high distress, significant anxiety and depression were identified by the cancer clinicians. Therefore, it means that we're not good at actually capturing them in our day-to-day practice. And the other element of distress also, that they're dynamic across the spectrum of cancer. There's a large longitudinal study that was done in America that include over 5,000 patients that shows that distress at the initial stage of diagnosis are quite high, around 75%. And over the 10 years period, it fluctuates depending on the time. It improves over a period of time. However, when they look at even at 10 years, as that about 50% still have a quite significant level of distress. So what do we see clinically then? So in psycho-oncology, when we got referral from our oncology colleagues or palliative colleagues, a lot of patients who were already being identified as clinically significant distress require input. What we tend to see in severe acute reactive distress, patient diagnosed with cancer, which cannot engage in diagnostic, unable to engage in treatment decision. Some of them have significant worsening of perceived pain, not able to tolerate treatment like chemotherapy and hormonal treatment. Some of them, the distress level are so severe that they require a period of time of stabilization. For example, people who present with severe anxiety or depression or steroid-induced mental health disorder, that the treatment was delayed due to their mental health conditions. Obviously, we see a lot of sufferings and poor quality of life in anxiety and depressive disorder. On those patient cohort who completed active treatment that are recovering from a following cancer journey, we see that smaller cohort of patients struggle to adjust to functional recovery. Some of them have problem with anxiety disorder, body image issues, and morbid fear recurrence. And obviously, we also see impacts of distress on caregivers and also family members in the form of burnout and grief. So what is the impact of cancer-related distress? One of the major impact is on overall mortality. This is one of the largest cohort studies that was published back in 2021, looking at link studies, looking at over 500,000 populations in America. So they look at all the variables that can impact on one's mortality, for example, access to care, health status, health risk behaviors, and when they adjusted all those confounders to the mortality rates, they still see that consistently that significant distress has a higher risk of rate of mortality compared to those who not experiencing psychological distress. So the age-adjusted cancer mortality there was about 437 per 100,000 per year, which is 41% higher than the rate of those who actually not reported psychological distress. How about impact? One other impact of cancer-related distress is depressive disorder. So we see about 16 to 25% of patients who diagnosed with depressive disorder compared to the general population. If you look at general population in non-cancer related patients, the prevalence of depression in those cohort would be around 6 to 8%. So it's almost triple or double or triple compared to what we see in the general population. And this is quite similar to other chronic conditions like multiple sclerosis, Parkinson's disease, congestive cardiac disease. And the prevalence of depressive disorder in cancer patients varies according to multiple factors. So there's a large meta-analysis that was published in 2021, which shows that the prevalence of clinical depression was about 27%. However, when they look at studies that use structured interviews, so structured interviews means that patient was actually interviewed by someone who trained in diagnosing depression, the figures was between 15 to 70%. When we look at types of cancer, this is well kind of consistent with a lot of other studies that those with GI cancers, such as colorectal cancer, gastric cancers, and lung cancers has a higher rates of depressive disorder compared to other cancer, such as gynecological cancers or breast cancers. And obviously that gender is a huge confounding factor as well, that even in general population, in non-cancer populations, that a female tend to be more likely to develop depression than male, around 2-to-1 ratios. So what is the impact of depressions in cancer patients? So when you use the term depression here, we are referring to clinical depression. So it means that someone with pervasive low mood for over 4 weeks period, have no interest whatsoever, have a sleep disturbance, not having poor energy. So clinical depression. When we look at clinical depression, one of the major challenges in cancer population is that there's a lot of overlapping symptoms in cancer, side effects and cancer itself with symptoms of depression. Fatigue, sleep disturbance, and poor appetite are very commonly seen in patient cancer, and is one of the core biological symptoms of depression too. And we know that depression also is an independent risk factors of suicide and suicidal behaviors in cancer patients. When adjusted all confounding factors, that depression itself remains a significantly independent risk factors for suicide. And having comorbid depressive disorder was linked to poorer survival outcomes regardless of the stage of the disease. So this is a study that was a graph that was taken from a studies from a prospective longitudinal studies and multi-center studies in US. They were looking at around 1,800 participants with lung cancer diagnosis within 3 months. As you can see that those who actually within the first 12 months of the diagnosis, that those who actually experiences depression has a lower survival rate compared to those who actually has no depressions. The studies then proceeded to look at beyond 12 months, those who actually have depression, subsequently diagnosed with depression and treated for depression. And they look at beyond between 12 to 60 months. And what they show is that if you look on the top, that those who actually in remission, the yellow line, have the same trajectory as those who never had depression throughout the durations of the cancer journey there. So therefore, those who actually have comorbid depressive disorder are more likely to have higher mortality rate, but also by identifying the depression and treating them, that you can actually change the trajectories of the survival rate on treatment. So, and we know that those who treated for depressive disorder shows improvement of survival rate, like those who are actually compared to those who are actually untreated. You can see on the blue line. So, how about suicide risk? So, if you look at one of the studies looking at suicide risk in cancer populations, the risks of suicide in cancer patients are about 2 times more than general populations. So in Ireland, our rate is between around 10 to 100,000 per year. So it's about 20 over 100,000. So, and the risks are much higher in those with advanced cancer. And the risks are much higher at the first year of diagnosis. So the study shows that the risks of suicide or suicidal behaviors are about 2.5 times more for the first year, and then it's slightly plateaued to about 1.5. And there's another study that should look at those who actually have acute myeloid leukemia in teenagers or younger cohort, and then who survivorship, and even after 15 years, those suicide risks persisted and has remained elevated, although yet be quite low, but still quite elevated compared to the general population due to the cancer. So the cancer itself is an independent risk factor for suicide when compared to other chronic physical disorders. Some of the risk factors that we know in suicide is having advanced stage and poor prognosis. So it's about 3.5 times more, higher. Those with older age at the time of diagnosis, those who are not in supportive relationship, those who live quite far or rural area, those who suffer from psychological comorbidity like depression and anxiety, and several types of cancers such as lung, colorectal, head and neck, and prostate cancers. Some of those risk factors are due to male predisposition. That's why we know that the risks of suicide in male gender are 3 times more likely in female. Therefore, some of the cancer are more predisposed to male, and they're probably one of the confounding factors. So the next one is that the impact of distress also impact on adherence to treatment. There's a lot of studies shows that depression scores or distress scores make people less likely to complete their chemotherapy. Those with higher distress also less likely to adhere to their radiation treatment with those head and neck cancer. Those who actually have high distress score and more likely to miss their appointments to the clinic. And if you look at the hormonal treatments area, also those with mood issues who actually develop mood problems in context of hormonal treatment are 3 times more likely not to adhere to their tamoxifen for the breast cancer treatment. And there's another study that also shows that patient who was diagnosed with early stage of cancer is about 90 sample numbers that who reported having mood and anxiety symptoms even pre-hormonal treatment. It's actually predictors for them not to adhere to endocrine treatment over time. So just a quick summary. So it's the importance of recognizing distress in cancer patients. We're not good at it. I do think it's important for us to somehow recognize them during our day-to-day clinical practice. Some level of distress is continuum, so there's significant level of distress that can actually interfere with one's ability to engage with treatment, it impact their ability to tolerate treatment. So those are cohorts of patients should be tried to be identified during your day-to-day practice and to be referred. And the subset in clinical, the significant distress can impact on patient mortality, in fact, their adherence to cancer treatment, and it can also cause clinical disorders such as depression, anxiety, and adjustment disorder. It does increase suicide risk. And there are other impacts also, for example, that those who actually have high distress scores more likely to present to ED, present to GPs, they're more likely to be admitted. They tend to have a longer length of stay in the hospitals, and some majority of them have poor quality of life. Thank you.
Okay, Fahmi, thank you very much. A reminder to everyone that the chat function is available for any questions afterwards. So we'll move on to our second speaker today, Dr. Aoife Lowney. Dr. Lowney is a consultant in palliative medicine at CUH and Marymount University Hospital and Hospice, a graduate of UCC. Dr. Lowney trained in palliative medicine in Dublin and Cork and did her higher degree in King's College in London and further research in Oxford University Hospitals, where she was appointed as a consultant in 2016. She has worked in clinical and academic departments in Oxford until her recent appointment in Cork, and her published work is mainly concerned with palliative care for patients with end-stage kidney disease, as well as the early proactive integrated palliative care in the acute hospital setting. Dr. Lowney is going to talk to us today about palliative care, clinical research, and research advances in 2024.
I forgot to unmute myself there. Perfect. There we go. Can you see my screen okay?
Can't see it just yet, Aoife.
Okay. Let me share again. And how about now?
Yep, we do. We've got it now, yeah.
Oh, okay. That's lovely. Okay, thank you for the introduction. So today I'd like to just focus on the why and in particular the how of early integration of palliative medicine in cancer centres. So as Eugene mentioned, I've spent the last kind of a number of years, 6.5 years in Oxford, and some of my talk will be inspired by my time there, but I started off here and I'm delighted to be back here again. There I am with my friends throwing the hat into the air there in about 2008 in UCC. So because we've got a mixed audience today, I wanted to just explain just very briefly what palliative care services do and how we function in Cork. So we're spread across all the hospitals in Cork, down as far as Castletownbere and up as far as the north of the county. And we have 17 nurses working in the community, as well as a nurse full-time in outpatients at Marymount Hospice, which is our purpose-built, really fantastic unit out at the Curraheen site, where we have 44 palliative care inpatient beds. And then we interface with all of the Cork hospitals as well. So we have quite a busy service. And you might ask, you know, given that we're so stretched and so busy, why are we kind of touting for more business and why are we looking for early integration of palliative medicine in cancer centres? And I suppose the collaboration between palliative care and oncology, even though cancer is only 50% really of what we do, because we see patients from birth until death who have life-limiting conditions, and we see patients with organ failure and neurodegenerative diseases and otherwise. But the case for proactive palliative care for treatable but not curable cancer can be kind of synthesized into 5 main important interfaces of our 2 specialties. So we've got epidemiology. When I left Ireland in 2016, the leading cause of death in Ireland was diseases of the circulatory system. And now it's malignant neoplasms at 30%. And cancer confers a high symptom burden, a heavy symptom burden, both in relation to the underlying problem and its treatment. That impacts along with other factors on health-related quality of life. We've got a mortality issue. So even though we're very supportive of colleagues in science and research and cancer and the great strides that have been made towards sort of, improving outcomes from cancer and curing cancer, there's still a huge mortality burden here. And we're not just concerned with quality of life, but also quality of dying. This beautiful sculpture from Celeste Robert, who is a professor of art history in Canada, is called The Weight of Grief. And I just put it there to remind me to say that actually early integrated palliative care is a protective factor for those left behind in bereavement. So this is a story now that is about 14 years old in terms of the benefit and the demonstrated benefit of early integrated palliative care in cancer centres. So as you'd expect, we see health gains, including improvement in health-related quality of life and patient and carer satisfaction. But 14 years ago, Professor Jennifer Temmel in Boston demonstrated in what's called, we call this the landmark, study of early integrated palliative care, that actually not only does it improve health-related quality of life and symptom burden and satisfaction with care as you'd expect, but it actually confers a survival advantage. And the first study dealt with people with metastatic non-small cell lung cancer, but this has been replicated in other disease groups, including patients with non-malignant terminal illness. So it enables people to better tolerate systemic anti-cancer treatment in the last year of life. And also there's this emerging story of reduction of healthcare costs, which we'll talk about in more detail. So this story is 14 years old, and now the systematic reviews of randomized controlled trials in the area are concluding that integration is the standard of care for patients with incurable but treatable cancer in a modern cancer centre. Now, the trouble with those of us who are kind of lobbying for this intervention and commissioners and funders of healthcare is the kind of what, when, and how of this intervention we're calling early integration. So let's look at that in a little bit more detail together. So in the past, at the inception of palliative medicine as kind of its own specialty, we had cancer care and a bit of palliative care at the end of life. And that was too late, and it caused all sorts of problems. And then over the last kind of 15, 20 years, we've had this concurrent model of early palliative care playing a little bit of a role at the beginning and more of a role at the end of life, balanced with cancer care. And the trouble with that is that it assumes that needs are linear. The future is supposed to be this so-called integrated model that is complex to deliver, but screens for needs at the point of diagnosis, much like what colleagues in psycho-oncology are describing. And here is Eduardo Barrera, who's a famous clinician and researcher in the Mayo Clinic in palliative medicine at Páirc Uí Chaoimh last year, talking to us about his approach. And so he proposes this model on the right of integrated supportive care in a cancer centre where there's systematic screening at diagnosis, consolidated appointments, a unified approach, integrated departments that aren't competing for funding but collaborating on programme development, rather than this current kind of model where we all get on very well, and we're working alongside each other, but we work in silos that may impact on patients in terms of conflicting advice and competition for resources, fragmented care and such like. So there's also a great paper, a Lancet Oncology Commission paper from 2018. And you see, all of the kind of experts internationally around the world, or many of them in relation to this area, have published this large document. And in it, they challenge the silos, both in healthcare systems, represented on the left of the slide there, in cancer centres, and even in departments of oncology, and represented by these vertical shapes, and then cutting through all of the traditional silos in healthcare are standardized care pathways. So this commission proposes that standardized care pathways and MDTs with changes at the system level should be used to coordinate activities of professionals in relation to early integration. And this, I've put in this paper at the end just to mention that this is not only true of early integration for patients with cancer. I and colleagues who are interested in kidney supportive care have also just published a way forward in terms of the core components of early integrated care for people with kidney failure. And you'll see this in the heart failure space, neurodegenerative diseases, and other so-called kind of palliative diseases that we encounter. So again, the kind of like, what are we talking about when we talk about these early integrated consultations? Professor Jennifer Temmel of that kind of landmark famous paper we spoke about there at the very beginning came to speak to us as well in Páirc Uí Chaoimh last year, and she's there with my other palliative care consultant colleagues and Roisin, who kindly chaired a session. So the bars here represent the proportion of palliative care visits that focused on each content area represented at the bottom of the slide. And kind of, as you imagine, symptom burden is a big concern of clinicians in these consultations, but actually coping is also a big concern of these early palliative care consultations. And in response to this, colleagues in the Mass General and in Boston have actually started, and this is a slide borrowed from Professor Jennifer Temmel, they have started to develop, really novel ways of enabling patients to cope. So rather than dragging patients to your cancer centre to have trouble with parking and compete and with other appointments, it's about developing novel ways of enabling this coping mechanism in terms of their care. Closer to home, when I started out in the NHS in England in 2016, there was a little bit of controversy because the Christie, who are paired with our cancer centre here, changed their name from palliative care to enhanced supportive care in respect of early integration in their cancer centre. And I was at a talk from a colleague, Richard Berman, where he talked about how, if palliative care were to ignore this revolution that's called enhanced supportive care, it would be rather like the way Kodak ignored the digital revolution and went bust, that he felt that there's a lot in a name, and following stakeholder engagement, they changed their name. So lots of different opinions about that in the specialty. But the other powerful thing that happened in 2016 was that the NHS made so-called enhanced supportive care a sequin, so commissioning for quality and innovation, basically kind of a financial incentive for trusts to partake in this intervention, for cancer centres to partake. And really usefully, Dan Monnery and Joanne Droney, who's a palliative care academic who lives in Cork and works in the Marsden and a clinician, have published these delivery models and health economics of supportive care. So that the evaluation of so-called enhanced supportive care in the UK pooled data across 8 cancer centres. So what did they find? So a good news story for the health service, represented in red there at the bottom of each graph is the enhanced supportive care service compared to national and regional population norms. So they reduced non-elective admission rates in the last year of life, reduced average length of stay per admission in the last year of life, and reduced A&E attendances in the last year of life. So financially in total, they spent across 8 cancer centres about £1.5 million. They saved £8.5 million, resulting in a financial saving of almost £7 million. So that's a really useful story. So the Irish context, is there anything to see here? What do we have to, what is there to see here? So Peter May, Bridget Johnson, Charles Normand and colleagues in Trinity did some really useful modelling of estimated numbers of deaths in Ireland from a disease associated with palliative care, kind of projected up to 2046. And depending on which model they were using, they're projecting a 68-84% increase in the number of people dying from a so-called palliative care disease to 2046. Now, if you want to compare that with the UK, the number for the UK for the same period is 25%, I believe. So we have a real intensity of aging situation here, where I think the number of people living with life-limiting conditions currently in Ireland outnumbers the number of people in the last year of life by 12:1, just because we have a very young population currently. And already Mairead Lyons, our new end-of-life care coordinator, tells me that there's been a 25% increase in CUH deaths from 2019 to 2023 alone, represented by those 2 arrows there superimposed on Peter May's graph. And 50%, the highest proportion of deaths in CUH actually happen in the emergency department, which I'm interested in because Peter May is currently analysing data, or has recently analysed data for me on the support study, which I was PI on in Oxford with colleagues, interdisciplinary colleagues, where we were looking at those patients with palliative care needs or who are at risk of dying presenting to the emergency department. And there was lots of things that came out of that study, but one was that this is a really polysymptomatic group, which would suggest that, you know, I'm not suggesting that nobody with a life-limiting condition should ever come to the emergency department, but it's just how can we sort of mold the health service and our integrated services to actually meet those needs. So digging around our national cancer strategy, there isn't much there in the way of early integration. We've got 2 KPIs around not treating people with chemotherapy at the end of life and referring to palliative care. But actually, since our cancer strategy was published, we had this paper in the American Society of Clinical Oncology in JCO, and apparently it was the most searched paper for months after its publication in 2018. And the Lancet Commission paper that I mentioned earlier says that integration should be anchored by management and policymakers at all levels of healthcare, and that this integrated model must be reflected in all national and international cancer plans. So I imagine that given that these were published after our strategy, that the one that's updated in 2026 should offer us more direction in respect of early integration nationally. So some kind of parting thoughts then, and some kind of personal reflections as well. So the work of early integration requires us to talk about things. You know, the proportion of those consultations in Temel's RCT in 2017, 14% of consultations were concerned with, you know, advanced care planning. So hoping, what we call in practice, hoping for the best, but planning for the worst. Okay. So it's my observation that in Ireland, we are brilliant at talking about death after it's occurred. And I think RIP.ie fascinates me since I left Ireland. I used to use it in talks with Oxford medical students all the time, and they were fascinated by it because you're allowed to generalize about your own culture. But actually, there's a bit of a conspiracy of silence then after a death occurs in the UK, is my observation. And we did a nice study in the hemodialysis unit in Oxford where, you know, patients would observe an empty bed and wonder if the patient had died beside them. They may have dialyzed alongside them for 20 years. And actually nurses felt they couldn't share the fact of the death because it was such a private matter. So we're different in that space. But I would say that there's been a lot more work in terms of public health around encouraging a public discourse about the inevitability of death, which allows people then to walk forward with advanced care plans and, you know, lasting power of attorney and those kind of conversations more comfortably in clinical practice. And here I am with a colleague who's a music therapy and a psychotherapist in Oxford, Tom Connor. I liked him because his mother was Irish. And every year we used to have a fantastic seminar in Christchurch College in Oxford where we would showcase kind of the posthumous music composed by patients dying in our hospice. And then, you know, this with colleagues in psychological medicine in Oxford. I was part of a group. We had 2 papers commissioned by the Lancet all about communication. And we also used to do this fun public engagement work with, there's Phil Selway from Radiohead, who's a resident of Oxfordshire, and some great literary people and that. And we used to come together and just really engage the public, pack the place out, talk about death and dying in a healthy way. So this isn't just about talking about death and dying in cancer centres. This is about a public health approach. But if you're sitting there wondering, you know, gosh, this is a good idea, but how do I actually introduce the concept of palliative care in my oncology clinic on the ground? Camilla Zimmerman and colleagues in the Princess Margaret in Canada have this lovely paper in JAMA in 2022 where they propose that early palliative care can be presented metaphorically as an umbrella to have in the case of rain. And that unfortunately, the umbrella of palliative care is often conflated with the rain of symptoms, complications, and distress that occur during progressive cancer. But palliative care is not the rain. Palliative care is the umbrella. And I'll leave you with that thought.
Thanks very much, Aoife. Lovely way to finish the presentation. Before we come to, I think we have one question there for Fami, and we may have some more for you. So maybe I'll give people a little bit of a chance. Just to draw together Fami and Aoife, beginning with St. Christopher's Hospice, Dame Cicely Saunders, just around the corner from the Maudsley Hospital in that little part of Southeast London. And bringing more up to date to your experience, Aoife, in Oxford, with the psychological medicine group and the series of really, very important liaison psychiatry studies by Michael Sharp and colleagues, the SMART oncology trials of integrated manualized depression care in cancer. Your experience of that more modern manualized depression care approach to patients who have cancer, as compared to, I guess, the beginning of the similarities between the origins of PALMed and the palliative care approach in Southeast London.
That's for me.
This one is for you before we come to Fami, if that's okay.
So look, working with Michael Sharp and Jane in Oxford, look, they have a very, very interesting approach to psychological medicine, where they embed themselves in departments. So the psychological medicine team, the liaison psychiatry team in Oxford call themselves psychological medicine because they are proponents of an integrated model with medicine. So the way that they fund their service is actually that they look for funding from individual departments in respect of their services. So we shared a full-time psychiatrist, Tom, who's incredible, with the neurologists. And it was amazing to have him as an integrated member of our palliative medicine team. And they would do the same. They would walk forward with, to hepatology and renal medicine in the same spirit. And actually, we borrowed from that model, and where we were asked to do joint consultations with renal medicine, we said absolutely, but actually we need to be funded in respect of our time. And this comes to the point about early integration. Early integration is not referral to a strapped palliative medicine or liaison psychiatry service. I doubt that we would see a survival advantage in respect of referral to a under-resourced service. Integration is about funding and appropriately resourcing services to work in an integrated fashion upstream. And, Michael Sharp and his department would have done that particularly well. And I could talk about that further. I mean, they were doing a study called the Home Study while I was there, and we worked closely together. Yeah.
Interesting, Aoife, and important to note that, of course, many of these approaches are borrowed from elsewhere, aren't they? The original, the depression care and cancer series of studies originated actually from depression care and diabetes by Wayne Caton in the University of Washington, almost not quite 20 years ago, but not too far off it, with similar improvements and cost-effective benefits and improvements in quality of life as observed in cancer patients subject to this. So again, your experience with palliative medicine and having been able to demonstrate it in other fora in the renal medicine, for instance. So I'm just going to move on to Fami, and the first question we have from Professor Sarah Kittel-Schneider. Dr. Kittel-Schneider, Fami, are there already results with regards to the causal mechanisms of the increased mortality in cancer patients, besides worse adherence to treatment, mostly behavioral factors or also neurobiological factors playing a role here? Fami, do you want to take that?
Yeah, I suppose a lot of studies are looking at depression itself. I think it's a cumulative factors that in patients who have depression in cancer, they're less likely to complete their treatment, so they don't get the full optimal treatment for their cancer. They're also less likely to tolerate the hormone treatment to prevent future recurrence. If you look in cohort of patients with severe mental illness like schizophrenia, severe psychotic depressions, there also evidence to suggest that when they do have cancer, they tend to present with more advanced cancer at the first diagnosis. So there's multiple factors or variables that actually impacted on patients who have depressions and the high mortality compared to who doesn't have depression. Saying that, though, there are probably some biomarkers in terms of inflammatory biomarkers that have relevance in terms of increasing tumorigenesis, maybe increased progression of cancer, but that's not really the area that I'm not familiar with anyway. Yeah.
Yeah, okay, excellent. And of course, you know, although it's a consistent finding, isn't it, this increased mortality among individuals with cancer who have clinically significant depression and or distress, what's a bit more disappointing is the absence of a benefit in terms of survival in those studies like the SMART trials, both in good outcome and poor outcome cancers, of treating depression on mortality. So again, you know, that, so it seems, Sarah, you know, some behavioral factors perhaps, but also some neurobiological factors that I'm sure you can comment on, related perhaps to stress neurobiology, including the HPA and immune function, etc.
Yeah, thank you. I mean, I think it's both playing a role, but I was not sure if there's any studies or ideas to what percentage or what, you know, those factors contributing to. But I definitely, like Fahmi said, it will be various different risk factors. But I think it would be good to, for me, like, because I'm interested in the biology, it would be very interested to know, because maybe then there could be also targets for interventions, right? So
absolutely, and I would say to you on that subject, one of the papers that would have influenced me the most, and you know, certainly one of the most cited papers of depression in cancer care, was a very small preventative study by Dominique Musselman in Charlie Nemirov's group back in the early 2000s, and she did a preventative study with antidepressant medication in individuals with malignant melanoma undergoing treatment with interferon. And you know, interferon in those days for malignant melanoma was exceptionally difficult to tolerate in terms of neuropsychiatric effects and very, very severe depression, and you know, finding a significant benefit in terms of depression prevention. And opening up a whole area of neurobiology around immune function and depression in cancer patients. So there's a huge amount of work to be done there, but you know, somewhat disappointing that the survival advantage hasn't been demonstrated by, you know, better and more comprehensive multidisciplinary interventions for people who have significant distress and depression and cancer.
yeah, definitely. No, I know the field of heart failure and depression much better because I also done work on that. But now it was really good to see what Fahmi presented, that definitely there is a advantage, and we need to identify and treat those people to improve their life expectancy, and that's very good. And now we need to look into the causality and find like more targets for interventions. But yeah, thank you. It was very fascinating.
Absolutely. We've got a little bit of time for a few more questions. So we have John Harford. Thank you for the excellent talk, Aoife and Fahmi. Fahmi, I wanted to ask you a few suggestions for screening questions for distress that could help improve our identification of it in our patients. Fahmi?
So the NCCN has adopted the distress thermometer as a screening tool. As if you remember the first slide of the visual analog of distress thermometer between 0 and 10, that has been used together with the problem checklist as a screening tools to identify distress. However, just to bear in mind, though, I suppose it's one thing to actually to do the screening. The second thing is what do you do with it and what resources are available to respond to that. So in US, then I suppose there's a lot more established pathways for patients who who reported distress. For example, if they reported distress in the area of psychosocial, they have a social worker department who will actually do their own assessment and do their own intervention. So there are multiple pathways, and those problem checklists that they use as a screening is not just to refer to psychiatry because it's above 5. It's more like a multidisciplinary type of approach to distress. Obviously, for us in Ireland here, we're still far behind that. We're not as developed in terms of primary care and even in secondary care. Therefore, using distress is good as a way of informing the clinicians when to refer, but at the same time as well to acknowledge that there are deficits or there are weaknesses with this distress thermometer. For example, a lot of people who recently diagnosed with cancer, they will actually score very highly on this distress thermometer. The first thing, the appropriate response is to watch and wait and redo it again after a period of time and then reconsider, and rather than using it as a more like a cutoff kind of scores and just refer. So.
Thanks for that, Fahmi. I mean, just to note the, the very important personality trait of optimism and having the glass half full, which brings me to the next comment, which is Professor Roisin Conley. Roisin, just to note that this is probably the best attended cancer seminar series since it started a few years ago, close to 60 attendees, a testament to the importance of the topics. Great talks. Yeah, we will all echo those comments by Roisin. Dr. Mary Jane O'Leary, Fahmi and Aoife, great talks. How do you think we can integrate better as a more complete integrated MDT for mutual oncology patients in our current resources? Aoife, would you like to take that one?
Yeah, I was just about to cycle back to, and it's probably related to Mary Jane's question, the comment about survival advantage and psycho-oncology. I mean, I think we're talking about, if you look at the early integrative models within cancer centers, palliative care and oncology, I guess we don't need to compete for that survival advantage. We're talking about not working in silos, but working in an integrated way, such that, it's very hard for somebody to address the depressive components of their illness experience if their pain is uncontrolled, for example. And we see that all the time. We modify the symptom burden, and then somebody is able to look at their distress. So I think you can't have one without the other. And I would say that survival advantage piece is attributable to the whole integrated pathway. So there's the treatment aimed at containing the disease alongside the modification of symptom burden and the joint endeavor to help somebody to cope, etc. Then coming to Mary Jane's question, it's tricky. I mean, in this, I'm looking at the figures from ED and CUH, and I'm thinking that there is no provision in Cork out of hours for patients with life-limiting conditions in the community, really. The only person who can go to somebody's house is a busy GP from a South Dock service or a paramedic. The paramedics aren't able to give subcut anticipatory PRNs and other measures. So we have a very, very under-resourced system, especially in respect of our community. And I wouldn't like to comment on community mental health, but I wonder if they're not awash with resources as well. And of course, it's not a siloed system, so we all interplay. But I guess I think it comes again from, I think the next cancer strategy document should have a national guidance about how to integrate under our current kind of resourcing. I think at a hospital group level and at a cancer center level, we need to have clinical governance, strong clinical governance meetings in respect to how we do business and how we integrate. And that might be in respect of our MDTs, joint clinics, our acute oncology outreach service, and our, the embargo at the moment, of course, is getting in the way of recruiting to funded posts, which is problematic, but hopefully the only way is up.
Okay, thanks for that, Aoife. I think we're I think we're out of questions there. Before the end of this particular meeting, I'd like to shout out, if possible, to an attendee, Diran Nidolig, who's a Maintain HRB-funded PhD student, who will begin recruiting in the coming year a cohort of adult patients with cancer, assessing psychological status and suicidality over time. So that's an exciting HRB-funded piece of research, which Diran will be the face of around CUH over the coming couple of years. If there's no further further comments, I don't think there are. We'll formally close the meeting. And would like to thank both our speakers, Fahmi and Aoife, for really stimulating us on this important subject of integrated biopsychosocial care, palliative medicine, and with psycho-oncology in cancer patients. Thank you all very much.